October is Sudden Cardiac Arrest Awareness Month. To raise and promote awareness for both medical professionals and the communities they serve, we've assembled a group of amazing educators to speak on a few in-depth topics related to this. We'll take a look at some high-yield information and hopefully provide answers to a lot of common questions. Some of these will include: what is sudden cardiac arrest or sudden cardiac death? What are some of the causes and risk factors? Sudden cardiac arrest versus heart attack. How are they different? What are some of the respective symptoms that may precede, and what are the appropriate actions? We'll talk about the association with things like long QT syndrome and other genetic predispositions. We want to look at the use of CPR, AEDs, some psychosocial aspects that are associated, and of course, the goal of this entire project, which is to culminate with healthcare and community education. So let's go ahead and jump in.
CardioVisual Community Awareness Month. Sudden cardiac arrest. Overview, causes and risk factors. The following data refer to research findings from the European Resuscitation Council, the American Heart Association, the German Center for Cardiovascular Research, and the Sudden Cardiac Arrest Foundation. Overview: approximately incidences out of hospital SCA, United States, 325,000 per year, and the European Union with 350,000 per year. Sudden cardiac arrest is the sudden loss of all heart activity. Due to an irregular heart rhythm, breathing stops, the person becomes unconscious. Without immediate treatment, sudden cardiac arrest can lead to death. Emergency treatment for sudden cardiac arrest includes cardiopulmonary resuscitation and shocks to the heart with an automated external defibrillator. Survival is possible with fast and appropriate medical care. Sudden cardiac arrest isn't the same as a heart attack. A heart attack happens when blood flow to a part of the heart is blocked. Sudden cardiac arrest is not due to a blockage. However, a heart attack can cause a change in the heart's electrical activity that leads to sudden cardiac arrest. Symptoms of sudden cardiac arrest are immediate and severe, and include sudden collapse, no pulse, no breathing, and the loss of consciousness. Sometimes other symptoms occur before sudden cardiac arrest. These might include chest discomfort, shortness of breath, weakness, and a fast beating or pounding heart called palpitations. But sudden cardiac arrest often occurs with no warning. Causes: the most common cause of sudden cardiac arrest is an irregular heart rhythm called ventricular fibrillation. Other common heart conditions that can cause sudden cardiac arrest: a coronary artery disease, an enlarged heart called cardiomyopathy, heart valve diseases, heart problems present at birth called a congenital heart defect, a long QT syndrome and other heart signaling problems. Risk factors: the same things that increase the risk of heart disease can raise the risk of sudden cardiac arrest. These include a family history of coronary artery disease, smoking, high blood pressure, high blood cholesterol, obesity, diabetes, and an inactive lifestyle. Other things that might increase the risk of SCA include a previous episode of SCA or a family history of it, a previous heart attack, a personal or family history of other forms of heart disease such as heart rhythm problems, heart failure and heart problems present at birth. Summary: sudden cardiac arrest is a condition in which the heart suddenly stops beating. When that happens, blood stops flowing to the brain and other vital organs. If it is not treated, SCA usually causes death within minutes, but quick treatment with a defibrillator and CPR can save lives. Remember, October is SCA Awareness Month.
Follow us on Instagram or YouTube for more upcoming content. Never stop learning.
October is Sudden Cardiac Arrest Awareness Month and serves as a time to recognize some of the great work that's being done in this area. Here are some facts. Sudden cardiac arrest is an emergency in which your heart stops beating suddenly. It is caused by an electrical problem that leaves myocardial cells without oxygen, and without prompt treatment within minutes, sometimes seconds, it is universally fatal. Now, sudden cardiac death is the largest cause of death in the United States, accounting for approximately 325,000 adult deaths annually and responsible for 1/2 of all heart disease-related deaths, with a peak age group in their 30s and 40s. Now, coronary artery disease accounts for most cases of sudden cardiac death, approximately 80%, with the most common arrhythmia being, you got it, ventricular fibrillation. Systems development, training, education in the pre-hospital setting is vital in treating sudden cardiac arrest because, remember, a third of all patients who have a cardiac arrest outside the hospital don't make it to the ER. And finally, remember that frontline care for managing sudden cardiac arrest in the form of CPR has only been formally recognized and endorsed for the past 60 years or so. So I invite you to be part of this journey of learning, educating, training to reduce the rate of this dreadful disease.
Hello, dear viewers, dear colleagues, dear friends. Me, Mustafa Naoushi, I want to welcome you today for our discussion, which is really important and really very interesting. Me and my colleague Matt Holden today from School of Education will discuss it and talk about it more. Our topic of today is atrial fibrillation and its relationship with sudden cardiac death. As we know, atrial fibrillation is the number one most common arrhythmia in the world. And we know that it has a huge impact on the heart overall, and it has the power to cause an increase in falls and mortality. And as we know, that also atrial fibrillation can increase the risk of having sudden cardiac death. How? Let's discuss it. As we know, atrial fibrillation is known to cause clot formation in the left atrial appendage, and will cause this clot to be mobilized in the left ventricle to the aorta to the brain, which can cause a severe ischemic stroke. This severe ischemic stroke will cause cardiac dysfunction because it can hit the insular cortex, and this can play a role in causing sudden cardiac arrest and sudden cardiac death. Overall, other than that, patients with cardiomyopathies, especially hypertrophic cardiomyopathy, that come with atrial fibrillation will have a higher risk of developing sudden cardiac death because the nature of the heart that needs more oxygen to pump due to these hypertrophic cells and myocytes they need more oxygen, need more supply. And due to the fact that they have the potential to also squeeze the coronary arteries. And when we have also the setting of atrial fibrillation with rapid ventricular rate, this may also cause stress and the need of having more oxygen and more blood supply. And we know that in atrial fibrillation, there is no adequate blood supply from the heart and to the heart, which is severe and can play a severe role in causing severe cardiac problems and cardiac arrest. Not only just because of the need of more oxygen and supply, and also the fibrotic tissue have the potential to cause more bypass for this atrial fibrillation as well. As we know as well, atrial fibrillation can induce cardiomyopathy and can be related to cardiomyopathy. As we know, like by example, patients with dilated cardiomyopathies, heart failure, and so on, can be having also atrial fibrillation. This atrial fibrillation can rather cause and be a factor of heart failure, cardiomyopathy, or vice versa. As we know, by example, atrial fibrillation can play a role to be causing arrhythmogenic induced cardiomyopathy, or basically atrial fibrillation induced cardiomyopathy, which is some type of heart failure, okay, induced mainly by atrial fibrillation. Because atrial fibrillation plays an atrial remodeling and the dilation of the atrium, and it can cause decrease in cardiac output and contractility and inadequate blood flow to the heart and from the heart to the organs, which is a problem, and can increase mortality for the patient. Sometimes when the patient have some type of valvular pathology or valvulopathy, like mitral regurgitation or stenosis, this can cause atrial fibrillation due to the pressure on the atrium, and this can cause atrial remodeling and can induce atrial fibrillation. Still, they can get increased risk of mortality and sudden cardiac death as well due to the cofactors present in the heart. Other than that, patient who present with Wolff Parkinson White, basically an extra accessory pathway, and get atrial fibrillation, have a high risk of sudden cardiac arrest and sudden cardiac death. Because when we have this extra pathway and we have atrial fibrillation, as you know, the AV node is trying its best to control this atrial fibrillation that is beating with a rapid rate. Yes? When we have a pathway, these fibrillatory waves will find a way to the ventricles faster and more efficient than the AV node because there's nothing blocking them when we're using the pathway. So more impulses will arrive to the ventricles and there will be no blocking, which will cause severe ventricular dysrhythmia and tachycardia, which can cause cardiac arrest and death. So what should we do? First of all, anticoagulants. Anticoagulants are gold standard to treat or to prevent, a way of prevention of blood clot formation in the left atrial appendage. Like basically novel oral anticoagulants, which are NOACs, which are factor 10A inhibitors, which are like rivaroxaban and apixaban, vendoxaban, and so on. And if a patient is present with valvular atrial fibrillation, they should take warfarin or synthron. So on. Other than that, to treat atrial fibrillation itself, we have two approaches: rate control, rhythm control. Rate control plays by using beta blockers, by first of all calcium channel blockers, to help us control atrial fibrillation and slow down the rate. Beta blockers like what? Like metoprolol, propanolol, or even like bisoprolol as well, which is also good. Calcium channel blockers like diltiazem or verapamil that plays good in the management of the rate of atrial fibrillation. Also, we can mix it or give out a digoxin, which is an inotropic and help us also control the atrial fibrillation by giving an inotropic effect to the heart and slowing down the rate. We can mix them rather like, by example, a beta blocker and digoxin. But also just be careful of the digoxin effect because it's known to have some secondary side effects on the heart, which are not very pleasant. Rhythm control or rhythm approach can be used by rather sodium channel blockers or potassium channel blockers like flecainide, procainamide, or the known amiodarone, or, by example, the dronedarone. These medications help us convert atrial fibrillation to sinus rhythm and maintain it. And can be, by example, an amiodarone can be given with a beta blocker to maintain rate and rhythm control. Patients sometimes can be candidates to cardioversion, but before they should be anticoagulated for 3 to 4 weeks, then doing an elective cardioversion to then get this atrial fibrillation sinus rhythm. Other than that, people who are not anticoagulated and need an emergent cardioversion should do a transesophageal echocardiography and should do cardioversion to see if there's any evidence of clot. And any patient who do cardioversion without any prior anticoagulation, they should start anticoagulation after cardioversion to 3 to 4 weeks. Last thing, patients with Wolff Parkinson White or any accessory pathway should get an ablation to prevent this atrial fibrillation from causing sudden cardiac arrest and increased falls and mortalities. And it is preferable to use prophylactic beta blockers, by example, to maintain and prevent and keep the patient safe for a longer time or more as much as we can from causing dysrhythmias induced by accessory pathways. And thank you.
Hello everyone, my name is Matt Holden. I'm one of the co-founders of Scope Education. I wanted to thank my friend Mustafa for giving a great in-depth view on AFib and sudden cardiac death. So it's my job now to kind of break down a couple of the topics. So first off, what is atrial fibrillation? Essentially, it is the shaking of the top part of your heart. You're just going to create an irregular heart rate as well, as you can see by the AFib rhythm on the bottom. Some of your risk factors include like your hypertension, which is your high blood pressure, your valvular heart disease, your cardiomyopathy, sleep apnea, holiday heart syndrome, which is essentially when you drink too much alcohol, which can cause you to go into atrial fibrillation, and thyrotoxicosis, which means that there's too much thyroid hormone, which puts stress on your heart. We want to keep your heart rate less than 80 beats per minute, and we can also give medications to convert you or use synchronized cardioversion, which is electrical therapy to get you out of atrial fibrillation. Now, once again, my name is Matt. I would like to thank Mustafa and the CardioVisual community for putting on this event, and hope you guys have a good day.
Down low on the QT. Now, I get a lot of questions from people on when do I worry about the QT? How long is too long? And what do I do with it if it's too long? Now, my name is Jen Carlquist, and I'm going to answer all these questions for you today. I've been a cardiology PA for the last 16 years and also have worked in ER medicine for the last 16 years. And I'm super excited to be collaborating with all of the collaborators you're seeing here, including CardioVisual, and thank you for having me. So let's dive into it. The numbers you need to know are here. How long is too long? So if you have a male, 450 and up, 450 milliseconds and up is too long. If you have a female, it's 460. Now, what do you do with this information in real life? Basically, if you want to just remember 460, it makes your life so much easier because that way you just have one thing to remember, 460. Because realistically, you're not going to do much between 450 and 460 anyway. The next thing you need to know is where to find the QT intervals. So this is an EKG that has our intervals here, and this is the QT here. It's 457, and you're only going to use the QTC. You're never going to use just the QT because it's uncorrected for rate. So if this was 457, we're in the sweet spot, and we don't need to worry at this time. The risk of having prolonged QT is what you see here on the screen, torsades de points. And what this is basically a twisting of the points. It's a flavor of VTAC where the points twist back and forth, and it looks like a ballerina ribbon that was twisted around. And this is what we're always concerned is going to happen when somebody has a prolonged QT. Now, what number are you most concerned about this happening? Well, that threshold is usually 500 milliseconds. It can happen under that though. And so if you have somebody who has a QT that's under 500, you still have to worry about it and make adjustments to prevent this from happening. Because once this happens, patients can either have cardiac arrest or they can just have a syncopal episode at the very best. But either way, this is not a good situation. This is why I really believe that med recs are a good thing. So why does the QT get long? There's a few reasons, and one of them is congenital. This is the most rare. It's usually going to be either drug-induced or there's going to be a problem with the electrolytes. Those problems could be low calcium, low mag, and low potassium as well. So this is why a CMP or even just a BMP is super important when you have a patient who has prolonged QT. Also looking at their med list. There are a lot of meds that can actually cause prolonged QT. There's so many, they actually dedicated a whole website to it. So I got to tell you that when I was first digging into this as a new medic, new provider, I was overwhelmed by all the drugs. So I looked for some good resources. Here they are. There's two of them I like. The first is a website. It's qtdrugs.org. And the next is an app called Credible Meds. Both free, they're both great resources, but in a nutshell, I will tell you that it is probably easier to go in and look through all the medications that you will interact with in a shift, for example, wherever you work, and know those meds. Things like some of the antibiotics. Thermax is one. Some of the antiemetics, Zofran is a big one, so the two Zs. And then looking at some of the other ones like the antidepressants. And looking through the list, figuring out which ones are important that you need to know. Otherwise, if you see a med and you're not sure, you can always reference either of these two. We've talked about the length that makes someone at risk, but there's also other risk factors. For example, females have a higher risk of going into torsades from prolonged QT. Add that to someone being on multiple QT prolonging meds. That's when you really get in trouble. The risk keeps climbing and climbing and climbing. If they have hypokalemia, definitely bank on having a prolonged QT. So hypokalemia from a bunch of vomiting, for example, and then if they're female and they're on multiple QT prolonging medications, like let's just say they're on Zofran, they're on Celexa, maybe they're on an antibiotic, it's definitely someone who's primed for this to happen. And they happen to have a history of a prolonged QT interval, and you would definitely have them on your radar for sure. Now, usually these patients know they have it, and there's a strong family history of it, and lots of their relatives have defibrillators. And that's kind of how you know that, oh, maybe that seizure wasn't really a seizure. Maybe it was actually Prasad Stefan. So let's do a case to wrap this up and really dig into what we've learned. So this is not a real patient's face, but it was a real case. This was a 50-year-old female who called EMS because it felt like the water ran out. Now, that's an odd complaint, but she definitely did have incontinence, which is concerning for her having some sort of loss of consciousness and or seizure, right? And had a history of neck surgery, was on multiple medications, including medications for depression and chronic pain, one of them being methadone. Now, that's a clue because methadone, as you know, is very QT prolonging. So here is what happened. EMS got her, laid her down on the gurney. She actually had to be assisted because she was about to have a near syncopal. They quickly put the monitor on her, noticed that she was in torsades. They administered therapy. She arrived to the ER with a CKG. This was her door time EKG. And you can see that her QT right here was 519, which is way over 460. It is so long that the machine actually notices it. So I did want to give you a tip on how to determine, if you don't have the QT interval, what the length is. And there's a really easy way to do this. And I just basically grab a paper and pen. I've been doing this for a long time, even when I was on the ambulance. And I go over and I measure from R to R, okay? And I make a line down the, well, that's not that good of a line, but let's just pretend that was straight, drawing with the mouse. And if your T wave, which is right here, is halfway between your R and R, that's definitely prolonged. So you would know that you need to know what this QT is on this patient. And the way that you can look at this visually is just knowing that T wave is the mom, QRS is the dad, T wave is the baby, and the T wave should be nice and close to its own dad. I've really enjoyed hanging out with you today. I hope that now you can walk away armed with some really quick, fast, and easy knowledge on how to spot prolonged QT, what the risks are, who's at risk, references you can use, and what to do about it. I hope to see you soon.
Hey everybody, my name is Zarina Sheralaya and I am an interventional cardiologist, one who specializes in treating coronary artery disease and heart attacks, among other cardiac conditions. And today I wanted to explain a little bit to you about two very common terms that we hear about in medicine. What is the difference between a cardiac arrest and a heart attack? So basically, a cardiac arrest occurs when there is an electrical issue that causes the heart to stop beating. And a heart attack actually occurs due to a plumbing issue, which happens because of a blocked coronary artery. There are different ways to deal with these problems, but my goal is to basically explain to you how to recognize these problems at home and what to do while you're waiting for medical attention to arrive. If a cardiac arrest occurs, there are a lot of different reasons why this could have happened to somebody. Severe blood loss, severely low oxygen levels in the bloodstream, drug overdoses. Some genetic conditions can lead to heart failure, and heart failure in and of itself can put you at higher risk for abnormal heart rhythms, severe infections, or even electrolyte disturbances can lead to a cardiac arrest. A cardiac arrest will ultimately cause somebody to become unconscious, and leading up to this, somebody might report shortness of breath, chest discomfort, severe weakness, or palpitations. So if you are in a public place or around somebody that's reporting this, or somebody passes out, your first step is to check a pulse, preferably the carotid pulse, and that's the artery right here in your neck. If you feel a pulse, then I would call 911. If you do not feel a pulse, call 911 and immediately start CPR. The most important thing to keep in mind is that the sooner you start CPR, the higher the likelihood of survival. Another important thing to keep in mind about a cardiac arrest is what kind of heart rhythm is occurring at the time. And the only way to know this is to hook them up to an automated external defibrillator, or an AED. This is something that is present in most public places. So it is an easy device to hook up, and once you turn it on, the device will analyze the patient's rhythm. Once the rhythm is analyzed, it will tell you if this heart rhythm is able to be shocked or not. There are two kinds of shockable heart rhythms, and those are ventricular fibrillation or pulseless ventricular tachycardia. These two shockable rhythms can sometimes indicate an underlying blocked artery or a heart attack taking place. So If these rhythms are occurring, then the device will tell you to administer a shock. The rhythm that is not shockable is called pulseless electrical activity, or PEA, and in that case, CPR is the best and only way to revive the patient and ultimately treating the underlying cause of PEA, or the cardiac arrest. We've talked about a cardiac arrest, so what is a heart attack? A heart attack then is more of a plumbing problem, which happens when there is plaque inside the coronary artery that has ruptured and a blood clot forms inside the coronary and blocks blood flow to the heart muscle. The longer that blood clot stays there, the more damage that is done to the heart muscle, and that can actually lead to a cardiac arrest due to abnormal heart rhythms or extensive heart damage, which can lead to heart failure or other complications. As an interventional cardiologist, we like to say that time is muscle, meaning that the longer that you wait at home with chest pain that could be due to a heart attack, the more heart muscle is dying off as a result. So even at that point, if we were to take you to the cath lab to open up that blocked artery with a stent, sometimes that heart function might not recover because too much time has gone by and a scar has already formed in the heart muscle. Please remember what the signs and symptoms are of a heart attack, and these symptoms can be very different according to gender even. So a lot of times people have chest pain, chest discomfort, jaw pain, or neck pain. This pain can even radiate to the back, shortness of breath, fatigue, and indigestion or nausea that's just not going away with your regular Tums. If you or somebody around you is experiencing these symptoms, please do not waste any time at home. Please call 911 if you don't have somebody to drive you to your local ER. After calling 911, if you have access to a baby aspirin and you do not have prior issues with bleeding, you can take a few baby aspirins while you're waiting for ambulance to arrive. As an interventional cardiologist, I have 90 minutes from the time that you hit the door in the ER to open up your blocked coronary artery. And that is the standard that we hold ourselves to be able to give you the best outcome possible in a very scary situation like a heart attack.
Dr. J, I'm happy to work with CardioVisual and all the amazing educators to this month talk about sudden cardiac death, and particularly in hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, as you know, is a genetic cardiomyopathy in which you have an increased thickness of the ventricle. As such, this leads to myocyte disarray and fibrosis, increased risk of having ventricular arrhythmias. These include non-sustained VT, ventricular tachycardia, or ventricular fibrillation, which can lead to sudden cardiac death. Let's go over some of the risk factors for development of sudden cardiac death in hypertrophic cardiomyopathy. This diagram nicely summarizes how to assess risks for sudden cardiac death in hypertrophic cardiomyopathy patient. This is from the 2020 guidelines for hypertrophic cardiomyopathy. So first of all, if a patient has sudden cardiac arrest, patient gets an ICD. For a secondary prevention, we'll try and prevent the next one. If they've not had a prior event, then you want to look for any risk factors, right? Risk factors include family history of sudden cardiac death, massive LVH, unexplained syncope, apical aneurysm, or ejection fraction less than 50%. If you have none of those, then IC may be reasonable. That's a 2A recommendations. Let's say if you have none of those risk factors, but you have non-SVT, then if they do have it, if they're a child, which have a higher risk of having arrhythmias, then you can consider it. If they're an adult, then it's a lower recommendation 2B. What if they don't have NSVT and you do a cardiac MRI and you have late gadolinium enhancement? Yes, then an ICD may be considered as well too. That's a 2B recommendation. Now, if they have none of these risk factors, don't have NSVT, don't have the high risk profiles, or don't have any MRI that's abnormal, ICDs are not recommended. Hope you found this helpful. Next up, we're going to have Heart Charge, which is going to talk about their personal journey with this condition and their journey to get an ICD.
It's Sudden Cardiac Arrest Awareness Month, and what an honor for us, Bethany and Hannah of Heart Charge, to collaborate with the renowned CardioVisual community to bring awareness to save lives.
8 years ago this month, I survived sudden cardiac arrest. We both live with a cardiomyopathy, which often leads to sudden cardiac death.
Sudden cardiac arrest accounts for 20% of deaths in many areas worldwide. 23,000 young people under age 18 die from sudden cardiac arrest each year in the U.S. alone. Currently, the survival rate is about 9%. It could be closer to 90%.
Women are 30 to 40% more likely to die because people won't perform bystander interventions. That's why we at Heart Charge are all about community awareness. Here's things we do that you can also.
A rally like the one we did in Washington, D.C., focusing on better outcomes for women.
putting on demonstrations at community events,
speaking to people in the streets,
school assemblies. We effectively taught students grade 3 and up in a fun way what to do in a cardiac emergency, how to use an AED, and where their school AED was. We share the warning signs of a cardiac condition.
Free community CPR and AED classes to train and empower people to act.
Print ads like on bus shelters.
Speaking to groups including school boards, parent groups, church groups, youth groups, town councils, committees, and legislators. There's ignorance at every level, and we need allies at every level. Instead of blaming them for inaction, we teach them and call on them for action.
Lack of awareness is costing lives. People don't realize how prevalent sudden cardiac arrest is.
People don't realize it affects anyone, anywhere, any age, any physical condition. People don't know they should and can use an AED and how safe and necessary it is.
People don't realize how easily survival rates could change with understanding and empowerment.
We are big proponents of teaching children. We've seen their enthusiasm and abilities, and we've seen them saving lives. Awareness and education should include age-appropriate trainings and materials to unleash the next generation of lifesavers. Hartford has those materials.
Social media can magnify outreach and inform people, especially young people. But remember, we're trying to reach the uninformed, and we have to reach them quickly. That's why we create entertaining but educational content.
We hope everyone will follow us at HeartCharged on Instagram and share our post. That's an easy way to engage the public. We'll gladly put on a bathing suit to get people to learn about hands-only CPR.
Here's other content we've created that has resonated well. A music video teaching the steps of AED use. Hundreds of thousands have seen this, and people remember what to do. Please share it.
We've done a lot of content on the women dying due to not receiving bystander interventions. Consider who will stop and read this article, and who will watch this. Community awareness should try to reach the entire community.
Through social media, we've met magnificent people like those of the CardioVisual community that we are proud to stand with in presenting information for Sudden Cardiac Arrest Awareness Month.
Through the efforts we've mentioned, we've made gains, including free in-school EKG heart screenings for 10,000 students, local AED legislation, state-mandated CPR and AED training for high school students, disseminating information to hundreds of thousands of people, and even patients deciding to accept implanted defibrillators to save them from sudden cardiac arrest.
Now let's make sure people get heart charged and know how to act in cases of sudden cardiac arrest. Follow HeartCharged for more resources and let us know what you're doing.
I heartily welcome you back to this channel. I'm Tuna Tekin. I'm a medical doctor from Frankfurt, Germany, and I'm teaming up again with CardioVisual, but this time with some help from Dowd Medics and HeartCharged. We are proudly presenting you the topic of the month, sudden cardiac arrest. And the topic of this video will deal with cardiopulmonary resuscitation, short CPR, that saves lives. So listen up carefully and try to learn something new.
Hands only. If you see a teen or adult suddenly collapse, it is important to act fast. Helping to save a life is easier than you might think. You have been performing hands-only CPR on an adult when the AED arrives. You have the victim face up on a firm, flat surface and are ready to continue hands-only CPR with an AED. You must remove all clothes that cover the chest, as AED pads must not be placed over any clothing or jewelry. CPR combined with using an AED, automated external defibrillator,
Automated external defibrillator,
provides the best chance of saving a life. If possible, use an AED every time you provide CPR. AEDs are safe, accurate, and easy to use. Once you turn on the AED, follow the prompts. The AED will check to see if the person needs a shock, and will prompt you to deliver a shock if needed or resume CPR. AEDs may have 2 sets of pads. Ensure you use adult pads on anyone who has shown signs of puberty and older. Turn the AED on and follow the prompts, which will tell you everything you need to do. Peel away the backing from the pads. Ensure there is nothing between the pad and the person's bare skin.
Plug in pads connector.
Plug the pad's connector into the AED if necessary. Follow the prompts and let the AED analyze.
Analyzing heart rhythm. Do not touch the patient.
And make sure that no one is touching the person. The AED will analyze the heart rhythm. If the AED tells you that a shock is not needed, resume hands-only CPR. If the AED tells you that a shock is needed,
turn down for what? Turn down for what? Turn down.
Shock advised. Charging. Stay clear of patient.
If the AED advises a shock, deliver a shock. Loudly state "clear" and make sure that no one is touching the person. Push the shock button.
Deliver shock now. Deliver shock now. Shock delivered.
Immediately resume hands-only CPR until help arrives or the AED prompts you to pause. You will likely need to repeat several cycles of compressions and shocks.
Begin CPR. Start with compressions.
Follow the prompts from your AED until help arrives. Try not to interrupt compressions for more than 10 seconds and follow the prompts from the AED. Let's hope you never have to use hands-only CPR. But know that CPR combined with using an AED provides the best chance of saving a life. If possible, use an AED every time you provide CPR. Again, if you see a teen or adult suddenly collapse, don't be afraid to start hands-only CPR. Remember, call 911 and ask someone to get an AED, then push hard and fast in the center of the chest until the AED and help arrives. Your actions can help save a life.
After seeing the last parts of this video, you are now an expert in doing basic life support by hands-only CPR and the usage of an AED. Let's look into a scenario where someone is going to the ground and collapsing. Now you will see how to react when you see someone going into sudden cardiac arrest. Enjoy.
Hey!
911, what's your emergency?
A man just collapsed and fell on the ground right in front of me. He's not responding.
Is he breathing?
No, he's not breathing.
Can you see if there's a defibrillator nearby?
A defibrillator. Is there a defibrillator around here?
Yes, I just saw one. I'll go
Bring
get
it, please.
Okay, we're sending an ambulance to you. Do you have your phone on speakerphone?
Yes.
Kneel beside the patient at chest height. Interlock your fingers, keep your arms straight, and start to press down hard on his chest. Very good. You're doing great. Keep going.
Shock advised. Shock delivered.
Can you hear me? Can you hear me? Are you okay?
Move aside, please. What happened?
He fell. We called 911, we resuscitated him and used the defibrillator to...
Okay. Can you hear me, sir?
Is everything okay?
Yes, my dad went into cardiac arrest in the street right outside.
Cardiac arrest? Is he okay?
Yes, there was a guy who reacted fast and saved his life.
That's great.
But he's okay now. I'm going now, okay?
Okay, tell me about it later.
Yes.
The opportunity to save a life is closer than you think.